Hello everyone, Medical Level Up here. We're back again with another video. Today's video is going to be all about T waves. Let's look at bleed V1 over here first. You see that the T wave is inverted over here. This is basically a normal variant and it can extend even to V2 as well. T wave inversion is sometimes normal in lead 3 as well, and this has been discussed in the previous videos. Here is the mechanism of how a negative current goes towards the positive pole of lead 3 and hence creates a negative vector which gives you a T-wave inversion in lead 3 as well. Both of these are normal variants. The next one is juvenile T-wave inversion, in which T-wave inversion is occurring from V1 all the way to V3. This is usually seen in young people or Afro-Caribbean people, and this is a normal variant as well. The next one is a right bundle branch block morphology. What you can see over here is an RSR prime pattern. Usually what this does is it causes T-wave inversions which can extend from V1 to V3, and these are known as secondary repolarization abnormalities. A similar thing is going to happen with the left bundle branch block as well. You can see the CCG which shows T-wave inversions in the lateral leads, the precordial leads, lead 1 as well, and this is basically a secondary repolarization abnormality as well. These two ECGs were taken from the same patient minutes apart. So the top one is ECG 1, and the second bottom one is ECG 2. You can see that there is dynamic T waves in these two ECGs. The patient had cardiac sounding chest pain, rising troponins as well. You can see lead V2 and V3 that they show dynamic T waves, which means that the morphology of the T wave is changing and there is a bit of an ST elevation over there as well. You can also see dynamic changes in the limb leads, mainly lead 3. These are basically a precursor to ST elevation. These are known as dynamic T waves. The next one is Vellum Syndrome. The Vellum Syndrome can either be type A or type B. Type A is going to have a biphasic T wave, while type B will have deeply inverted T waves. This is basically indicative of critical LAD stenosis. You can see these over here. In the right clinical context, of course, if the patient has cardiac sounding chest pain, then you think of Vellum Syndrome. The next one is pulmonary embolism. Pulmonary embolism is signified by this classical pattern known as the S1, Q3, and T3. Research says that it's prevalent from 10 to 50% of cases. You can see a deep S wave, a Q wave, T wave inversions, and T wave inversions in the anterior inferior leads as well, which is suggestive of embolism. The next one, we've already discussed this on my blog. This is LVH with strain. What you get is an asymmetric T-wave inversion with ST depression. In the right clinical context, this is to be interpreted as LVH with strain. You're going to have voltage criteria for LVH as well. The next one is cerebral T-waves. Increase intracranial pressure, subarachnoid hemorrhage, hemorrhagic stroke. These are going to cause deep, bizarre T-wave inversions, mainly in the precordial leads. So these are known as cerebral T-waves. The next part is basically camel-shaped, humped T-waves, or also known as the U-wave. There's many variations of the U-wave, and this happens basically because of hypokalemia. So this is also a variation of T-wave. So the U-wave. One of the variations is known as Nicolicam T Waves. Make sure that you check the potassium of the patient when you see these kind of T waves. So always make sure that there's no life-threatening hypokalemia. The next one is hyperacute T waves. Now, what exactly is hyperacute T wave? Well, there's no clear-cut answer to this. This is a precursor of a STEMI as well. If you can take the preceding QRS complex, fit it under the corresponding T wave, such as this, then yes, you can say that this is a hyperacute T wave. There's also different cutoffs where you can calculate the T by QRS ratio, which is used to differentiate between a normal ECG versus a precursor STEMI, or an old MI versus left ventricular aneurysm. There's different cutoffs. It's more than 1.5 for this one. And to detect an LV aneurysm, it's more than 0.36. So if it's more than 0.36, it's an MI. The next hyperacute T waves you're going to see is basically narrow-based, tall tinted T waves. Always check the potassium. This is a precursor for hyperkalemia, actually. Thank you so much for watching. Don't forget to like, share, and subscribe to the channel. As always, feedback and questions are